Discover the 2 must-know precautions when choosing confirmatory tests for secondary hypertension. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, Board-Certified Nephrologist, Certified Hypertension Specialist, Internal Medicine Specialist. See video description for disclosures. A 59-year-old man is referred for evaluation of hypertension that had remained above 165 over 100 millimeters of mercury while he was taking amlodipine 10 milligrams daily, hydrochlorothiazide 25 milligrams daily, and metoprolol succinate 100 milligrams daily. 5 years earlier, he required emergency department treatment for lip and tongue swelling after his first lisinopril dose. He was instructed never to take an angiotensin-converting enzyme inhibitor again. His father had hypertension and ischemic stroke at age 71 years. He has osteoarthritis treated intermittently with naproxen, rheumatoid arthritis treated with prednisone 5 milligrams daily, and gastroesophageal reflux disease treated with omeprazole. He does not smoke and drinks 1 glass of wine nightly. He reports no other drug allergies. 4 weeks before repeat endocrine testing, hydrochlorothiazide and metoprolol were replaced with verapamil sustained release and doxazosine. Naproxen was stopped. At this visit, blood pressure is 156 over 94 millimeters of mercury in both arms, pulse 74 beats per minute, respiratory rate 14 breaths per minute, temperature 37.0 degrees Celsius, and oxygen saturation 97% on room air. He has no edema, pulmonary crackles, or cardiac murmur. Mild proximal leg weakness is present without synovitis or focal neurologic deficits. Laboratory studies show sodium 145 millimoles per liter, normal, 136 to 145 millimoles per liter, potassium 4.1 millimoles per liter, normal, 3.5 to 5.0 millimoles per liter, bicarbonate 31 millimoles per liter, normal, 22 to 29 millimoles per liter, creatinine 1.0 milligrams per deciliter, normal, 0.7 to 1.3 milligrams per deciliter, and fasting glucose 94 milligrams per deciliter, normal, 70 to 99 milligrams per deciliter. Urine microscopy is bland. Plasma aldosterone concentration is 18 nanograms per deciliter, laboratory reference 4 to 31 nanograms per deciliter. Plasma renin activity is 0.3 nanograms per milliliter per hour, laboratory reference 0.2 to 1.6 nanograms per milliliter per hour, and the aldosterone to renin ratio is 60. Adrenal computed tomography shows a 1.6 centimeter left adrenal nodule without a right-sided mass. The endocrinologist plans confirmatory testing before considering adrenal venous sampling. Which planned confirmatory test is contraindicated for this patient? Option A, fludrocortisone suppression testing with inpatient potassium and blood pressure monitoring. Option B, captopril challenge with oral captopril after prior angiotensin-converting enzyme inhibitor angioedema. Option C, oral sodium loading with 24-hour urine aldosterone collection after potassium correction. Option D, seated saline infusion testing after potassium correction and volume assessment. The correct answer is option B, captopril challenge with oral captopril after prior angiotensin-converting enzyme inhibitor angioedema. The contraindicated confirmatory test is a captopril challenge because he previously developed lip and tongue swelling after his first lisinopril dose, indicating angiotensin-converting enzyme inhibitor-associated angioedema. Captopril is also an angiotensin-converting enzyme inhibitor, and prior angiotensin-converting enzyme inhibitor angioedema is a contraindication to captopril exposure because recurrence can threaten the airway. His positive screening pattern with aldosterone 18 nanograms per deciliter and plasma renin activity 0.3 nanograms per milliliter per hour produces a verified aldosterone to renin ratio of 60 and supports further evaluation for primary aldosteronism, but it does not override this medication contraindication. Seeded saline infusion testing after potassium correction and volume assessment may be considered if he has no clinically important volume overload risk. Oral sodium loading with 24-hour urine aldosterone collection after potassium correction is also a potential confirmatory approach when sodium loading is safe. Both require correction of hypokalemia and assessment for severe hypertension, heart failure, or kidney dysfunction. Fludrocortisone suppression testing with inpatient potassium and blood pressure monitoring is labor-intensive but not contraindicated solely by a prior angiotensin-converting enzyme inhibitor reaction. His normal creatinine, absence of edema or crackles, and normal potassium reduce immediate concern for volume overload, although each protocol requires individualized safety assessment. In summary, prior angiotensin-converting enzyme inhibitor angioedema specifically excludes captopril challenge. Other confirmatory tests remain possible if their sodium, volume, potassium, and blood pressure requirements are met. Primary teaching point: a previous angiotensin-converting enzyme inhibitor angioedema reaction contraindicates rechallenge with captopril. Secondary teaching point: correct potassium and evaluate volume-related risk before suppression testing for primary aldosteronism. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.